I'm pleased to welcome three experts for our second listening session. We've invited them to present on payment model features that contribute to successful population-based models. You can find their full biographies on the ASPE PTAC website, and their slides will be available online later. Presenting first, we have Kristen Krzyzewski, who is the Chief Strategy and Program Development Officer at LTC ACO. Please begin, Kristen.
Thank you, and thank you for inviting me to participate in the session today. I'm looking forward to discussing our population that we serve as an ACO, and that is the long-term care beneficiary population of Medicare beneficiaries residing in nursing facilities. So next slide, please. So we offer a unique perspective, I think, to the committee, in that we are an enhanced track MSSP ACO, and we are the first ACO to serve this particular subset of the population that resides in long-term care facilities. We started in 2016 under Track 1, and in our second agreement period that began mid-year 2019, we migrated to the enhanced track. And we originally we were part of the Genesis nursing facility chain, and we originally started with the Genesis physicians and nurse practitioners serving the beneficiaries that resided in the Genesis facilities. In 2019, we began to expand outside of Genesis, recognizing that there was a lot of provider interest in this community to participate in value-based care, and that we had some unique experience that we could bring to the table. And so we began to expand, and now in 22, we are serving approximately 20,000 beneficiaries that reside in 39 states with over 1,800 participating providers. So that's about 600 participating physicians and 1,200 participating nurse practitioners and PAs. And so I just wanted to highlight how we are unique in many ways. And that is, again, with a relatively small population participating in the program, we have a very large benchmark per beneficiary. You can see here over time from 2019 through the latest settled period through 2021, our benchmark has been 30,000 or over per beneficiary per year. And that compares to the traditional ACO, the average ACO serving the Medicare population, which has a benchmark of around $11,500. So we're significantly serving a higher risk, higher needs population. And you can see the savings that we've earned, COVID aside, because COVID certainly hit our population in a unique way, and we were very challenged during 2020. But setting that aside, we've earned the Medicare program in gross savings on a per beneficiary, the highest of any ACO in the program in 2019 and in 2021. And I say that in 2021, noting that we still have some impact from the COVID PHE and the pandemic. So along the way, we've improved in quality, and we're sharing in 21 at the highest sharing rate, quality adjusted sharing rate of 75%. So next slide, please. Thank you. So with all that said, we serve a really unique population within the program. Not within long-term care, but within the ACO program. 96% of our folks are indeed institutionalized. So a couple of folks fall out along the way. They may transition back to home, but the bulk of our population resides in the long-term care facility. 88% of folks are dual eligible, and you can see the comparison here as we go to all MSSP ACOs, and this comes directly from our files from CMS, how we compare. We have a very elderly population with nearly 40% of our population age 85 and over. We serve a more diverse population than traditional ACOs, and we use a lot of primary care. The model for this population really is primary care driven. Clearly, they have a lot of comorbid conditions, and you can see the incident rate of conditions compared to other ACOs. But the bulk of that is coordinated in the facility through the use of primary care physicians and nurse practitioners and PAs. There's a high utilization rate of hospice, as you would expect, and we have a higher rate of death for this population. That a significant portion is at the end of life, and we're helping manage quality and cost of care. Typically in a beneficiary's final years of life. And just to note again, COVID, again, as you might expect, 46% of our population in 2020 had a diagnosis of COVID compared to 4% in the overall ACO population. But a smaller portion of our beneficiaries actually had what CMS classified as a COVID episode, in that CMS, to exclude those costs from population, you had to have an inpatient hospital stay. And a lot of our folks, because the PHE waived the 3-day hospital stay, went straight to a post-acute or a SNF bed within the facility. So we had a lower rate of excluded costs that were truly COVID. So as you can say, we serve a unique population. It's well defined, and you'll hear through my message today consistency in saying that this unique population warrants a population-specific approach. So next slide, thanks. So first of all, there is a large market. Talking about a specific population, while there's certainly a lot of Medicare lives still in fee-for-service program, to say about 800,000 is a significant population is maybe seems strange, but given that this is a high-cost population with high risk, we think it's a unique, worthy population, subset of the population to focus on, with lots of low-hanging opportunities to improve quality and the cost of care. And the population is really underserved from a Medicare Advantage perspective. Only just over 100,000 lives are in Medicare Advantage I-SNPs. And so this population really still resides in original Medicare. And, I've shown our slice, we're serving about 20,000 there. Since there've been other programs, high needs ACOs that serve this population, and other MSSP ACOs have come in to try to serve this population as well. So there's a small slice participating in value-based care, but the vast majority are still in what I'll call original fee-for-service, unmanaged, sort of from the perspective that we're talking about today. So this all compares to, the average Medicare population, where there's almost 50% in MA and a higher rate of uptake in value-based care programs. This population is underserved. And this population, folks do ask us, well, gee, aren't we trying to move away from institutionalizing beneficiaries and keeping them at home? And yes, we applaud that, and Medicaid incentives and managed MLTSS is doing a lot to keep people in the home. The population, as we know, is aging, and there will continue to be a need for folks moving to long-term care. And as the population ages, the population that does reside in facilities will get older over time. And so it'll become higher risk. So again, a greater need for improved coordination of care. Next slide, please. Thank you. So things that we think about and we've thought about and we've sort of lived through in trying to make our population work within this program. It has been a challenge, because this program wasn't necessarily designed for providers serving folks in this setting. But some of our biggest challenges, we've worked through a lot of the challenges in the program to make this successful, but we have recommendations on how we can do better and get more providers participating. Because at the end of the day, these providers want to participate in value-based care, but it really has not been designed with their specific population in mind or their specific needs. So one of the things that is often a hindrance, one of the biggest things, is just the TIN exclusivity. I know this is not a new issue, but having a whole practice being required or hold a billing TIN to participate in the program, while they may serve a mixed population, that it creates confusion for trying to manage and isolate this true subset of the population, true long-term care. And most of the providers serving folks in this setting also serve individuals residing in assisted living facilities, potentially in the community. And so it's a mix. It's an array of risk profiles and potentially benchmarks. So trying to navigate that, and I know ACO Reach has some things to allow participation at the MPI level. We think there's opportunity to further isolate within an MPI or a TIN a true population that is long-term care, and it's easy to do. CMS does it for us with that long-term institutionalized factor. So it's doable. We just need a way to attribute just that subset of the population and not penalize providers who serve other populations in their practice. Attribution is tricky for this population. A lot of folks are served through nurse practitioners and PAs, and we have found, interestingly enough, that requiring one physician visit from a participating provider can slow attribution by the true primary care providers. And so, again, ACO REACH has allowed flexibilities in attribution, and it's something, again, and not requiring a physician visit, but just looking at the plurality of care. There are ways to reward providers who are delivering care to this population that are unique among other ACO populations. Minimum participation levels are a challenge here. Thinking about this as really a building by building, maybe 120 beds in a building, not all are long-term care beds. To meet 5,000 minimum threshold requirements in MSP is a challenge. And I think that has been one of the primary reasons folks have not been able to participate in the program to date, have interest, but haven't been able to. So moving on, there's a lot here, so we can maybe circle back with in the discussion and questions. But benchmark development, this is a real concern for this population. As we think about moving towards administrative benchmarks in the future, which we support, we want to caution folks as programs are designed, and actually just brought this up at NACOS to CMS last week, that the program is really designed to think about inefficient versus efficient participants in the program. But folks and ACOs and providers that serve a really complex, high-cost population will often be deemed inefficient and higher cost relative to regional performance, risk-adjusted regional performance. And so if we can't get the risk adjustment to actually accurately capture the risk of the population, then we are going to have problems under an administratively set benchmark. And so I urge CMS, the committee here, to think about wanting to encourage ACOs and providers serving higher complex populations, that they need to think almost as there's a third rail here in a third bucket. You've got inefficient, efficient, and then you have ACOs serving complex populations. There almost needs to be a third bucket. Quality measures certainly weren't designed for our population, and we've had to work within that. Costs, the PHE, certainly, we saw how the methodology sort of penalized our population compared to others. Telehealth, we want to continue to be able to use that because there are many attractive opportunities of coordinating care and improving care, and then just trying to increase opportunities to data share. So going on to the next slide, and I'll wrap things up and we can move it. But the key drivers for participation, as I said, there's a lot of interest. We see interested parties. They are concerned about risk of participating. So we participate as an enhanced track. We don't pass that risk down to providers, and we think that has helped providers in their willingness to join the program and come in and migrate and improve performance over time. But then I also cannot understate the importance of the 5% macro bonus, and our concern that going away is really going to discourage providers from participating. So there's certainly obstacles. I think I've covered some of those in the last slide here. Again, just reiterating that these providers want to participate in the program. There's a big opportunity to get folks, migrated from original Medicare to value-based care, original Medicare. And so how do we do it? And I urge the committee to think about how we can go back to CMS to encourage faster action and uptake among this providers serving this specific population. So thank you.
Thank you so much, Kristen. We're saving all comments and questions from the committee until the end of all presentations. Next, we have Jeff Micklos, the Executive Director of the Healthcare Transformation Task Force. Please go ahead.
Thank you so much, and I appreciate the invitation to be with you today. And the task force is a longtime observer and supporter of the PTAC, and I just want to say we really appreciate kind of how you're going about your work these days. It's really helpful to the field to have this August body weigh in with recommendations, so appreciate being here today. Next slide, please. So the task force is in its 8th year. It's an industry consortium comprised of providers, payers, purchasers, and patients, all committed to accelerating the pace of change to value-based transformation. We support our members across all their lines of business and different populations that they serve. And so the overview slides that I will give you today are kind of at that higher level, reflecting a variety of perspectives within our membership. Next slide. Next slide, please. Thank you. To give you a sense of our progress over those 8 years, we had set ourselves a goal of having 75% of our payer and provider business in value-based payment arrangements by 2020. We made great progress along that goal. We now have extended that goal to be 2025. I'll talk a little bit about some of the kind of limitations of that numeric goal, but it's still aspirational, and it really applies for all populations that our members serve. Next slide. And this will be in your materials, but just to give you a sense of kind of who's within our membership, we have large national payer and health systems. We have smaller, we have single state blues plans. We have other transformation support companies. We have a wide variety of perspectives within our membership. Next slide. So it's always important for us when we talk about kind of designing a total cost of care payment model is to step back before you get into the specifics of a payment model and make sure that you have a foundation in place that can be successful. So certainly a cultural commitment and serious government buy-in remain critical first steps. The task force has kind of prepared some practical resource tools for its members, and are also available on our website around conducting a readiness assessment and doing some internal benchmarking. It's important that organizations know their own capabilities and limitations before choosing a particular payment model. And then what APM opportunities are available to sustain change, and how do they align with the populations you're seeking to serve? So clearly, when you have a Medicare payment model from either MSSP or the Innovation Center, the parameters are pretty set, whereas there's a lot more flexibility in commercial models, Medicare Advantage arrangements, and Medicaid managed care to have those private parties to collaborate and partner in the best way. And so we also think that you need to conduct a partnership evaluation. In addition to evaluating yourself and your readiness, it's also important to look at the strengths and weaknesses of a potential partner and whether they are ready for now and capable over time. And I say that in the context of our 75 by 2025 goal, in that we had a number of members who really sought to sign up arrangements that would meet that standard, but then found that some of the providers weren't necessarily ready to go in that direction as quickly. And so it's really important that you make sure you evaluate that. It's important that relationships are developed and they can move along the continuum and be productive and not get into situations where you have to unwind arrangements. When we talk about choosing an accountable care payment model, we really talk about that in a variety of ways. We have members that are all across the continuum. Some are at the early stages. Some have been doing this for a long time. We look at them as really on-ramps and low-risk models, whether that's one-sided risk on total cost of care or at-risk care management payments. We see a lot more in the moderate risk category right now with two-sided risk on total cost of care, capitation on a limited cost of care, or even capitation on limited cost of care with one-sided risk on total cost of care. So we're seeing that more in the commercial space and evolving in the Medicare Advantage area as well. And then we have full risk models where we're talking about capitation and with two-sided risk or global budgets. Certainly there's an ongoing interest in all of those, and there's certainly a feeling within our membership that it would be great to have some more full risk options available in the Medicare program currently. Next slide. So for on-ramps and transformation supports, as everyone knows, addressing the investment risk and the business risk and financing of the startup costs of infrastructure needs to overcome any barriers to entry. I think Micklos has reported that the costs for setting up an ACO are $1 million plus to begin operations. We're really excited about the ACO investment program that's been proposed in MSSP for 2023. The idea of being able to provide upfront payments to help new providers come on board is really important to widen the on-ramp to have new providers come in. I also think the way that proposal is designed is really effective in that there is an expectation that the investment dollars will be paid back. But however, if the entity would not realize shared savings by the end of the 5th year, those funds can be kind of held harmless against returning those funds, which creates stickiness in the program, allowing for providers to really have the full experience of a contract term, since we know that it takes several years really to kind of settle in and get to a place where you're operating in a successful way. And of course, we continue to see at-risk care management payments that also help with provider capacity building, frees up the provider community to be able to serve individual patients as needed, as opposed to relying on revenue, focusing on fee-for-service. And then when we see in the private kind of partnership space, in the commercial and some of the innovation that's happening in managed care, public program managed care, we see design of capital allocations and resource contributions that are impacted by the form of the arrangement. So it could be a direct contracting arrangement between a purchaser member and a provider. It could be a joint venture between payers and providers, or even a clinically integrated network. And so again, a lot of variability, understanding kind of what you're trying to achieve and what your partners are able to achieve in the near term is critically important at the beginning stages. Next slide. So for ongoing participation and protections and our incentives, they need to be properly calibrated financial incentives and rewards, and they need to be revisited and grow over time. It's very important for arrangements to be revisited periodically and adjusted as appropriate. I think as we've kind of seen our life cycle go, there's a lot more discussion about what are those kind of checkpoints, as it were, over the term of a contract, and the importance of trust between partners and arrangements to be able to address things as needed as time goes on. We want to ensure the proper flow through of incentive payments to individual providers. There's been concern, of course, that it's more at the accountable entity level, and that individual providers are not necessarily seeing full benefit of what their work is, and therefore not maximizing their move to value. I'm sure it's been discussed today already. Eliminating the ratcheting effect of current benchmark policies is really important to driving sustained provider participation, especially in a Medicare portfolio that primarily relies, if not almost exclusively relies, on voluntary arrangements. So creating more reliable and predictable benchmarks is critical, and we also think that heading toward administrative benchmarks in Medicare is a good idea. And then progression to incentivizing advanced risk arrangement adoption. So we've had a lot of interesting conversations over the past few years inside the task force about that the right way to push the providers along the risk continuum. Some felt that the pathways was a little fast, but now are concerned that maybe the proposed changes to the MSSP won't move folks forward. I think it's critical for any payer, public or private, to recognize that they should have a variety of opportunities that meet the providers where they are and what they're able to accomplish. And I think some of our more advanced providers would say the same thing about their payer partners. And then progression to incentivizing advanced risk adoption, may employ some additional business tools that are critical to kind of supporting here, whether it's implementing reinsurance or stop loss protection against downside risk. I think in the Medicare models, one major concern has been the retroactive benchmark adjustments. Those have really obviously soured some participants, and most recently we've seen kind of a departure of a large number of organizations because of a recent retroactive benchmarking change in the bundle payment for Care Initiative Advanced program. Next slide. So engaging specialists in accountable care arrangements, and I know we'll get into this in more detail in the discussion, but this continues to be a challenge for many performance-based providers. There's a number of reasons for that, but there's also one of the incentives related to the advanced APM bonus that we believe is critical to continue to move toward value, and we definitely support legislation to do that this year. Would be great if we could achieve that objective. But also by the way that they calculate these scores, there may be a disincentive to really engage with a specialist because it may affect an organization's ability to recognize an advanced APM bonus payment. So that's a concern, something that future policymaking should address. And then I think we're concerned about the future of the CMMI clinical episode models. We think more models addressing special engagement strategies are desirable across all model types. I know Liz Fowler, CMMI Director Liz Fowler, made a comment last week at the NACOS meeting that we'll have more guidance and thinking from CMMI this fall on that topic. I will say also inside the task force, we are seeing more activity in the commercial space in trying to find out these effective arrangements to engage specialists, which can take many different forms. Next slide. Task force has spent time really thinking about value-based payment model overlap and alignment generally. And because APMs are becoming ubiquitous, it's making it difficult to kind of manage patient attribution and measure model impacts and appropriately credit providers for the cost and quality improvements. So as we look at these things, we really think that they need to work together and we need to find a path forward and not have a one-size-fits-all. So we think precedent determinations are important to drive desirable outcomes. That's more prevalent kind of in the public programs really than in the commercial sector. We are a supporter of testing, nesting of clinical episode models in ACOs. We'd love to see the CMMI to do more in this area. And then also we recommend kind of CMS pursue a hierarchical model alignment strategy that sets a consistent and predictable beneficiary attribution policy that shows preference to higher risk arrangements. Certainly those total cost of care models should be recognized for the overall benefit that they're providing. And there's a number of directions we can talk about later about what policy could look like in that area. Next slide. And I think what's really critical inside the CMMI strategy refresh is the multi-payer alignment prong of what they're looking to achieve. We all know that there needs to be greater consistency across models to increase adoption. Quality measurement is the one that gets a lot of conversation. However, there can be alignment can come in a bunch of different forms as long as we're trying to move away from an industry built on fee-for-service competition. It does require a shared vision for how we move forward in with regard to multi-payer alignment. But APM alignment does not mean a lack of competitive differentiation either. There are definitely things our members talk about that are competitive elements to their value-based care strategies, but there's also increasingly a recognition of areas where competition shouldn't rule and that both payers and providers would be better served by trying to align key methodologies that includes risk adjustment and patient attribution methodologies. Next slide. So with that, I look forward to the conversation, and I'll turn it back to our moderator.
Thank you so much, Jeff. Next, we have Clare Wirth, the Director of Value-Based Care Research at the Advisory Board. Please begin.
Great, thank you. Good morning, everyone, and thank you for having me. If we can flip to the next slide, it should just be a title slide. For those of you who are less familiar with Advisory Board, we are a healthcare research firm based out of Washington, D.C. that's been around for about 40 years now. And I'm just delighted to share some of our latest research with all of you. This year, my team has been focused on commercial risk. So the next 10 minutes or so, we're going to lift off and move from our Medicare focus and into commercial, how it has evolved, its future, and some key differences in terms of the care model and population health management approach from Medicare. So I want to stay on this slide for just a moment and get to the punchline first. Commercial risk in many ways will decide the fate of value-based care. And our contention at Advisory Board, and I'm sure many of you all, is that this movement towards value must keep going, though I know a lot of folks are skeptical given the pace of change that we've had to date. This does beg the question of commercial risk. Medicare has had clear progression, a clear path towards value. And for commercial, I think it's not a matter of if or when, but it's really a matter of how. And we see two main possible scenarios playing out for the future in commercial risk. The first one is an industry-wide reimbursement standard in which we see both Medicare and commercial plans really aligning. So we would see the commercial landscape follow Medicare's lead in this way, especially Medicare Advantage with that population level type of payment structure and continuing along that sort of glide to risk. The alternative scenario, the scenario below that uses a completely different game plan from Medicare. So really we see a split in which the commercial sector would anchor the payment approaches around bundles, around episodes, focused on really consumer steerage. And so what this means long term is that it would mean all industry players operate in a hybrid world with split incentives much like what we have today, but in a more total cost of care ambition. Now, there's two key themes that I want to get out here. First is that each of these have trade-offs in terms of what each player can gain, how hard it is to accomplish, and where we net out as a whole in terms of an industry. And it is a question of which path we do achieve more savings, more efficiencies, either by mirroring the public approach or really tailoring the model to commercial needs. And of course, there's various pain points that would be different in terms of the roadblocks and giving up certain revenue streams. So trade-off is one key theme. The other key theme I want you to hear is agency. So in commercial, payers, providers, other support participants, they're the ones really designing these types of models for themselves, which is why, if we can go to the next slide here, that is why we have not seen one clear roadmap in commercial. And we've mostly seen various experimentation. There's been a bunch of fits and starts in commercial risk. Some are still going, some have failed and disbanded. So I have a few examples here. So for example, Boeing and Providence, that fell apart. The finances didn't quite work there. Haven, we certainly saw some big splashy headlines, but ultimately not necessarily the right timing, incentives, market power, or true collaboration. Some that are continuing to go, Cigna still has a big emphasis on commercial, as well as at the state level, Blue Cross Blue Shield North Carolina. That is a really great example of a statewide effort to keep things moving. Some of you all may look at this and think, well, we've had a lot of experimentation in the Medicare side too, and that's of course right. As you all know, CMS, we've been experimenting and then changing course, redefining, ditching models, encouraging the growth of the ones that have worked. But generally, there's a roadmap to follow to ingest toward population-based risk, and that's something that's continuously pushing in that direction. In Medicare, we don't have that same consistency because there's not that central governing body, and so these models, the models that have continued, what we've seen of organizations that have been successful in the commercial risk space, they have a heavy emphasis on that upfront investment that's necessary and have focused and are really keen on what their partners' needs are and actually compromising with one another. And those that have failed really have not had that same emphasis. Another key difference with the commercial space is, of course, the role of employers here. Employers have to agree to these trade-offs as well in terms of what sacrifices they're willing to make, especially ones that their employees will tolerate when it comes to certain steerage. And we've seen focus on the centers of excellence, but of course, not much further. If we can move to the next slide here, the role of employers is not the only key difference in the commercial risk landscape. In fact, the day-to-day clinical model can be quite different from what we've worked on in the senior population. So for example, in commercial, we do tend to have younger, healthier patients. So a lot of what you need to do in commercial risk is prevent people from developing those conditions in the first place, making sure they don't overuse care when they need it. And of course, there's a focus on primary care utilization and condition management. Of course, in Medicare, there's a far greater emphasis on multiple chronic condition managing across multiple different specialists in addition to primary care. In commercial, it's of course about whenever a patient does have a need, making sure you're getting them to the most cost-effective treatment options, providers, and site of care as quickly as possible. And lastly, of course, we have the engagement of consumers. The commercial population certainly prefers lower cost, that's a big emphasis, and prefer the convenience as well. I want to move to the next slide. So after all of that and talking about the key differences of the population health approach, it may sound like the industry should take a fundamentally different direction when it comes to commercial payments compared to Medicare. And that does beg the question of whether this commercial risk path is really all that viable. But I want to remember here that we have two potential options, each with different trade-offs. So we have one where payers, providers, all the players involved here compete to find these high spend target areas and address partnerships on those. So for example, identifying 3 to 5 core bundles in these high cost areas unique to commercial. So for example, labor and delivery, and drive majority of savings there. The flip side, of course, is that we can't have so many different bundles that providers are managing a bunch of different pieces here, and they're undermining their greater work rather than taking a holistic picture. That said, though, it could really be narrowed and focused in on the commercial patient's clinical needs and savings opportunities. The other scenario here, diving a little bit deeper, moving towards what Medicare is already doing, following a similar model, by definition is going to be more feasible for providers in terms of a day-to-day administrative basis. But we're hearing more and more frequently that there's the complex quality metrics. I know that Jeff mentioned that before. There's a lot of emphasis on how do we create some consistent quality metrics. But there's also some common processes that we could have include here with payers. Ultimately, the industry does have to decide between having everyone follow a similar path as Medicare, which would be perhaps easier for providers, likely harder for employers to justify, or pursue more narrowly scoped risk options in commercial. Not necessarily clear which one nets out the savings or improvement for the broader industry in terms of what we can get behind. I want to move to my next and final slide here. So I wanted to make you all aware that my team has done a lot of work here in this, and it's at advisory.com/VDC. The vast majority of what we've published this year is publicly available, so please feel free to dive into some of those resources. That said, I do want to end on this key message. I don't think that there's any world in which there's no commercial risk whatsoever, but of course either path does come with challenges. When I speak with plans, providers, life sciences executives all across the industry, one thing has become really clear, which is the journey to risk is as much of an adaptive challenge as it is a technical one. And so some of the most progressive leaders in value-based care have certainly cited that they have fears. There's huge organizational cultural changes that have to be made in order to make progress. And so that tells me that this is very much of a choice that leaders can make and shape. And so now is the time for providers, payers, and others to really dictate what the future is going to look like. Of course, in terms of Medicare, but especially in commercial, it's a place where they have more agency. It's a place for them to play and have further control over what it is. And so ultimately, the path that these leaders will take will decide whether the industry unites around one industry-wide standard or remains split. Thank you.
Thank you so much, Claire. We want to thank each of you for sharing your very interesting and unique experiences. We have some questions for all three of you to speak to, and then, time permitting, committee members will be able to ask questions too. So first of all, the first question I'd like to ask is, what specific kinds of payment model design features and financial incentives are most important for developing successful total cost of care models? What does the evidence tell us about the effectiveness of these approaches? Jeff, would you start?
Sure, I'd be happy to. So I think we think of questions like this thematically to say what attracts, retains, and moves individuals to greater accountability. And I think first and foremost, an appropriate investment in primary care has to be at the center of this. We certainly have advocated for an additional risk track in the Medicare Shared Savings Program for Medicare populations, which could include a primary care capitation component on that. We really think that the primary care models that have been tested in the Innovation Center have been really kind of a mixed bag, but getting primary care right is critically important. And then I think the on-ramps are really important as well. We want to make sure that organizations that can take on risk have access to those type of models. But I definitely think that Claire makes some really important points about the viability in the commercial sector. But I think on-ramps is really important. As I indicated in my opening remarks, I think the new proposal in the Medicare Shared Savings Program is a good idea in that way. I think, but transparency and clarity of the model design and goals up front is really important. We need to be able to kind of have when people will be paid, how they will be evaluated on their performance clearly, and having access to appropriate data to trust but verify the numbers. Data and access to appropriate data continues to be a main kind of complaint within our membership. And then I will come back, at least in the Medicare context, and make a plea for some sort of mitigation strategy with regard to these retroactive benchmark adjustments. We view our relationship, our members' relationship with CMS as a partnership, and we know CMS works hard to get the benchmarks right, but when they do need to correct them, there's significant financial consequences. And as partners together in the program, we do think there should be some level of mitigation strategy to recognize kind of what could be a very material impact on providers, and we do believe that the agency has some authority to be able to mitigate that impact, so we'd ask them to kind of think about that. And then I think access to data to support the care delivery and being able to communicate effectively to the patients about what they're achieving is important. It may not go to a financial methodology or incentive, but there are appropriate programs out there that are holding specific providers accountable for how they are communicating with patients and consumers, and that's critically important so the consumers understand what's going on for them in the total cost of care arrangement, and also to counter any concern that the use of the word value is actually a limitation and not a positive.
Thank you. Claire, how about from your perspective?
Jeff hit on a bunch of things that came to mind for me as well. The one thing that I'll go back to that he mentioned in his talk, but didn't necessarily circle back there, was the role of specialists in value-based care. So certainly agree that primary care needs to become the anchoring model with anything in terms of population health management and the ease of which we can do, and not just relying on the PCP, but the entire care team in that work, right? Making sure that APPs are deployed as autonomously as possible by the state in which they operate in, having nurse care managers either circling around, virtually working with patients, and ideally in person, and integrating behavioral health into primary care, and pharmacists as well, huge benefits there. In addition to that, having specialists supporting primary care providers and managing these more complex patients. How do we create greater opportunities for collaboration? How do we make sure that specialists are sort of reverse referring patients back to primary care once they're well managed in specialty care? How do we make sure that they're available for one-off questions to make sure patients are getting the right treatment and managed well in primary care? So that was the other thing that came to mind. And of course, we've hit it a few times, but how can we look for areas with consistent metrics across these areas, and even thinking about what kind of consistency we can drive across these very different patient populations? What could we possibly keep consistent across commercial and Medicare?
Thank you, Claire. And Kristen, how about from your perspective?
Sure, thank you. Yeah, so I have some very tactical recommendations. So just because, boy, we're living it, we're trying to get these providers from year to year to participate in this program. And, what do we really worry about? What do our providers really worry about? Well, number one is the benchmark. And, there's no special message there, right? Everybody's worried about the benchmark, and the benchmark has to be sufficient, or these providers are going to be scared and will stick to fee-for-service. So we were very encouraged, and I like to think of it as, CMS wrote a love letter to us with this physician fee schedule draft that came out, the proposed rule, especially to ACOs that are serving complex populations. I mean, all ACOs, there are good things in there for all ACOs, but those of us who are serving complex populations, we're very happy to see the prior savings adjustment. Again, all ACOs would be happy about that, but we have we're staring down the barrel of a huge ratchet at the end of our agreement period going into 24, based on the savings that I showed in my presentation. If left as it currently is, we would substantially reduce our benchmark, and a lot of the incentives to participate among our providers would be eliminated off the bat. So by offering a prior savings adjustment, we applaud that. That's wonderful. The unfortunate thing is, well, you need to think about complex populations when you design that adjustment, because right now it's capped at 5% of the national fee-for-service expenditures adjusted for each enrollment type. Well, that's not risk adjusted. So that cap is nearly meaningless to an ACO that serves, or providers that serve, a high cost population. So we of course put these things in our comments. So we applaud CMS, but we want them to take it at take everything a step further and think through the impact on folks and ACOs and providers serving the highest complex, highest cost populations out there. And, we were certainly happy. One way that they did it we think they did it really well was this, the negative regional adjustment cap, that they're minimizing that, and then they're providing an offset to ACOs that serve a population that is highly complex or high risk. So that is, one great way to say, okay, we understand there's an interplay between efficiency and inefficient relative to regional performance, but you've got to factor in the risk of the population, and it may not be fully captured at the highest risk levels under the risk adjustment methodology. So, again, great things are happening, but take it a step further. Messages, always think through what are the incentives to ACOs that may be considered higher cost than their regions, but just due out of the sheer population they're serving. And one other thing that is critically important to growth in this program is that 5% bonus on Part B billings, that incentive that will go away at the end of this performance year. That's payable in 24. We think that really offsets the goals of trying to recruit providers into the program, is by letting that expire. And we know that's not in CMS's hands. That requires congressional activity and action, but we certainly are fully behind that being extended and creating an incentive. And likewise, I know the last panel listening session talked about sort of penalties for folks who want to stay in fee-for-service only and not participate in, and that may be one way, again, if there are greater disparities between if you participate in greater incentive and upside in folks participating in value-based care and APMs versus staying in fee-for-service, that your financial opportunities are going to weaken over time. That widening that disparity is also important to drive performance and participation in these programs. Thank you.
Thank you, Kristen. That's a perfect transition to our next question, which you've started to address already, which is what payment methodology features are most important for managing the interrelationship between primary care and specialty care when designing population-based models? If you can highlight any that are particularly important for high-cost, acutely ill patients, that would be helpful. Kristen, if you would go first.
Yeah, sure. So I probably will be short in this area and let the others, Claire and Jeff, speak to this, because our population, again, is really the bulk of the care delivery is through primary care in this setting. And they live in the long-term care facility. It's nurse practitioners and the physicians that are seeing them, and certainly then the staff of the facility that are there day to day. Of course, there is some coordination with specialists, but primary care is what we have to invest more resources in this setting. And so I may not be fully answering your question, but for this population, we really want to have the leverage to offer a capitation to our participating primary care providers that recognizes the outsized role they play for this population in coordinating care. So with that, I'll turn it back to you.
Thank you, Kristen. Jeff, how about from your perspective?
Well, I think Kristen continues to emphasize the importance of the advanced APN bonus payments, and the task force completely agrees. I think that the financial incentive and the added payment to create that alignment is critically important, and so something that needs to happen, because if it doesn't get extended by Congress, we're going to be in a situation where it's going to be better for many providers to be back in MIPS, and that's definitely moving backwards, and so that's an important point. I think what we hear from accountable entity levels is their ability to engage their network providers really hinges upon to be able to reward them for their behavior. And so more timely reconciliations of shared savings payments and things of that nature that can go to the entity level, that can be distributed then to individual providers more timely. A 2-year lag period is a major challenge, especially for new providers that really you're trying to entice. I think we had one remark recently about, looking at clinical episode models, that it's hard to maybe engage a specialist in that way when they need to wait for their shared savings, when they could really realize that funds just by doing a few additional procedures. So the more timely reconciliation around these payments, I think, is critically important. Again, we did mention at the outset that the way that people think about engaging specialists probably also depends on who's leading the total cost of care model. So we definitely hear within the task force membership that our health system-led ACOs, have an easier way to think about how they manage both a clinical episode model and an ACO model, and have very specific thoughts about how they could integrate that. And I'm sure that's true of multi-specialty physician practices too. But as Kristen just indicated, for many ACOs who really have been focused on that primary care piece, the strategies really continue to be challenging, and I think we probably need to see some innovation kind of beyond the Medicare space right now to understand that. And I do think that there's more discussion going on for other populations on that front.
Thank you, Jeff. Claire, how about from your perspective?
From my perspective, when we did research on this last fall and we interviewed provider organizations, hospitals, health systems, and medical groups, they were pretty unclear with how they should be thinking about where they engage specialists in value-based care. A lot of them had focused on primary care and hadn't yet gotten to the specialist area. And when we did that research, we really identified three main places to engage specialists. So the first was, how do we think about reducing low-value referrals? So creating some kind of referral considerations to keep more patients in primary care, or thinking about how to maximize primary care access and capacity. So that was the first area. The second was e-consults. This was an area folks had a lot of interest in, and I know there's some reimbursement in this area, but perhaps an opportunity for more to provide that incentive so that specialists will answer the phone for PCPs and get that guidance back to them as quickly as possible in terms of next step for that patient, for those patients. And then the third area was referring patients back to primary care. So once they're well managed in specialty care, we see patients in that specialist office for far beyond that, and making sure specialists are able, they have the guidelines in place and the training to communicate to patients referring back to primary care. So I know that middle one, the e-consults, are an area for specific payment model changes, but those are the three opportunity areas that we gleaned from our research last year.
Very helpful. Thank you. Committee members, if you have a question, would you mind tipping your name tag? And I want to get an idea of how many people may have questions. I think I'm going to go to those next. Angelo, would you like to go first?
Yes, thank you. So my first question is for Kristen. And first, I want to applaud you for addressing the long-term care population. It sounds like you've got a great model in place. I was just curious, though, looking at some of your early slides, you mentioned that you had 20,000 beneficiaries in 39 states. So when I do the math, that turns out to be about 500 patients per state and 11 patients per provider. So I'm just curious how you're engaging your providers, keeping them interested and activated to such small populations.
Yeah, no, you're right. We are sort of not even an inch deep, really, in this opportunity. There's so much more that can be done, and so much more engagement to be had. But first of all, this is a big transition for this population, right? This population, in a way, we're at the beginning days of value-based care. For the provider serving this population, it might as well be 2013 or 2012 and not 2022. So it's really going slow. It's talking about clearly the financial incentives, the portion of shared savings, rewarding them really for the first time in what they're doing for this population, because they oftentimes have just been the overlooked providers in this community. So we're saying we see you. Unlike maybe the ISNP model that goes about working with the population that requires facility contracting, this is saying we need you, the primary care physician or a nurse practitioner in this setting. We see you. We're going to reward you for the role you play at long last. And so it's communicating what value-based care, 101 is all about, trying to find these providers in the setting, getting their attention. And then also that 5% bonus. We cannot overstate the importance of that. That really is attractive because these providers don't just serve this population, they serve others. And if they can earn the 5% bonus through this vehicle, then that can be applied across the other populations they're serving. So that has been a big reason that we've been able to garner their interest and participation in the program. Now, once they're engaged, it's about starting them really on that pathway towards away from fee-for-service and the critical, again, basics, sharing the data. They've never had any of this data. It is a big investment of getting them up to speed, engaging with them on a monthly basis, just so they understand the true performance of their population. So it's sort of ACO 101. We, as I said, are back to 2012 days, but arming these providers with the information has been the key to change, as well as then continuing to support them with best practices and really engaging and sharing those best practices, because we do have some big groups in that, so they aren't equally dispersed. We have small groups, we have big groups, and trying to share those best practices from organization to organization, and how we impact on medication management. The drive to deprescribe for this population is very important. So we're making inroads there, as well as the use of palliative care and advanced care planning. So not rocket science, but it really is the blocking and tackling and giving these providers a voice and a view into the role and the important role that they do play.
Thank you.
Sure.
Kristen, you really started to tap into another one of our key questions, which I'd like to turn to Jeff and Claire. So when you think about different providers, different levels of readiness to move towards value-based payment, what do you think are the most important strategies for increasing provider participation? How can we prepare providers to assume greater levels of financial risk and encourage investments in care delivery transformation? Claire, I'm going to turn that to you.
The softball question. So this reminds me of some comments that I heard from Liz Fowler last fall that I think are really true, which is, how do we recreate this sense of inevitability around the future of value-based care that has, quite frankly, been lost in the last 5-6 years, I want to say. When the ACA came out, I do feel like there was this incredible focus and fire underneath executives across the country that, oh, if we don't do this, it's going to happen to us. And that sense of inevitability has really been lost. So I think the clearest messages that can be sent around this is going to happen in the near term, and we really are going to achieve this, is going to be valuable. The other thing is, of course, getting hospitals more on board in some form or fashion. We've talked a bit about penalties around their reimbursement, but when I speak with independent medical groups, I think that they are pretty much understanding the future as value. Of course, they don't have to worry about the hospital revenue and losing that and demanding their own, destroying their own demand in that regard. And so I think that would be the area that I focus on.
And Jeff, how about you?
Well, I just want to echo first Claire's point that the imperative for change has lessened. It certainly has. And I think it was starting to happen, but probably exacerbated by the COVID experience. I think it's interesting, as we've gone over the last 18 months and had periodic conversations with our board about the impact of COVID, it actually shows that it actually should be a driver between kind of more resilient opportunities when you're sharing risk between payers and providers. The providers didn't have the cash flow concerns that some that were not in those arrangements did. So they felt like they were on much, greater footing. And of course, some of the payers within our membership who didn't have those type of advanced risk arrangements helped the providers out in other ways, but realized that that was a stopgap measure and probably not a way to think about long-term sustainability and resilience. And so that's a theme that kind of continues to percolate here. And then I think a new theme that people are grappling with, and it's kind of related. We have the inflation issue and the impact on business currently. That's clearly a clear and present danger. But that's exacerbated by workforce shortages. And so there is that positive view about value that if you work smarter and more efficiently, but through team-based care, you can address some of those workforce shortage issues, which are likely to grow and not kind of decrease over time. I think it's also showing the changes of site of service, whether it's, increased use of telehealth, some real hospital and home models that are very interested out there. So it is kind of the macro environment, I think, that's affecting that. But when I think it comes down to engagement of individual providers, the ability for those who are new to it to kind of get that upfront per member per month care management fee gives them flexibility to think about practicing differently. So that changes their mindset a bit. And I also think that, good old peer-to-peer transparent, evaluation across a team always seems to be a great driver. If you're not performing well versus your peer group, that always seems to be a good incentive to move in the positive direction. And so I think some of those kind of still operational techniques are in the beginning are important, but we do have to continue to reemphasize why this should still be the right direction for the system, even if the moral imperative is not burning as bright in C-suites these days.
If I may, Jeff made me think of something. Jeff, completely agree with everything you just said. One thing that I found interesting was after the pandemic, right after, even during, I heard from so many provider organizations, well, this is why we need to move to value. We have no fee-for-service reimbursement coming through the doors, and yet we're still getting our risk-based payments. And that has very much lessened over time. In fact, I think that the lesson a lot of provider organizations took was the benefit of a hybrid model so that you have wartime and peacetime types of incentives. So the value-based care reimbursement certainly helps during wartime types of eras, but not to get rid of fee-for-service entirely. So we can't rely on just that alone to be the propeller to value.
Kristen, did you want to add anything in addition?
Oh, always. Any opportunity. So, it's as Claire and Jeff said, I mean, it's incentives, right? It's incentives, it's got to be more attractive appearing than fee-for-service, right? And we've got to continue to move in the right direction to make sure that the incentives are sending folks and causing them to align with these value-based programs versus going back to fee-for-service and looking in MIPS. Heaven forbid. Sorry. Let's not go back to MIPS, right? They like participating in APM and being excluded from MIPS. So incentives, number one. But again, so much of what we have to say, and I think speaking for any ACO, any provider group serving complex populations, is CMMI need to think about how the program that they're designing and the methods that they choose to deploy impact the ACO serving complex populations. You want more of these populations in the program. You want 100% of lives. Well, here are there groups of lives that represent a disproportionate amount of the costs and expenditures. And so let's make sure that everything we do, we think it through, because the numbers game are in for the traditional population, right? And so programs, policies are designed thinking with that in mind, and inadvertently could potentially hurt the groups that serve these highest cost populations. So it's in many different ways that we see sort of the nuances that get applied that hurt our types of providers and ACOs. And so, we need to eliminate those. And again, I think CMS recognizes that, and they're trying to do things and offer programs that reward providers serving this. But let's just make sure we think through those incentives and the impacts. And one last thing that I'll speak to is just going back to sort of confusion. There's confusion among programs, DCE, high needs populations, DCEs, and TIN overlap, and even just going through our last application cycle. I know there was feedback coming back through NACOs that trying to add new ACO participants to the MSSP program were getting hit with TIN overlaps. Even if it was an MPI and they participated long ago, there were unintended impacts and which are slowing the growth potentially in the MSSP program. So providers are confused, certainly in the space we see as they have outreach. There's prospective alignment only in DCE, there's retrospective and MSSP. It creates confusion, and while we applaud there are positive things from ACO REACH, and we think 100% upside track and primary care capitation are really important to incorporate into MSSP. We certainly like the idea of building on the chassis of MSSP and avoiding disruption and confusion among providers, because that will slow the participation potentially down the road.
If I may just add one more comment that I forgot to make, and I think it's critically important for the PTAC. I'm sure many of them are aware of it. I think the challenge in the Medicare space right now, or one of the challenges in the Medicare space, is how effective the Innovation Center can really be right now. You have a situation where, as a business proposition, people are somewhat reticent to invest in those models if there's not going to necessarily be a favorable evaluation and an opportunity to scale that model broadly. So too many folks have invested money in models that have, basically either ended after a time certain or have been continued in a kind of a successor model that really doesn't have long-term success either. And, the one thing we talk about at the task force is, in some ways, the APMs are becoming a victim of their own success, because they're ubiquitous now in a variety of different contexts, and it's really hard to find a comparison group. And so I don't think that the chance of scaling a model out of CMS is getting any easier. If anything, it's getting harder. And so it's really important, at least in the Medicare context, that we think about MSSP as the platform for innovation, on top of which we can layer the innovations that kind of come through the center, because I do think fundamentally the construct that's in place for the Innovation Center is becoming more challenging for them every day.
It's a really interesting point. Lee, I'm going to turn it to you.
Yeah. Great point, Jeff, and that's actually a kind of a nice segue. This question goes to Clare, but I'd like the other two commenters' thoughts on it. And I really appreciated your first slide, Clare, and focusing on risk. And I think I agree with you that probably after, the ubiquitous pilots and all the many flavors through CMMI, it's what the commercial marketplace does with risk and value-based care that's going to decide the tipping point. Mm-hmm. But I was a little bit struck and alarmed essentially by your described split between, it's either going to be an industry-wide approach in risk methodology, or it's going to split, and commercial and public payers are going to go different ways in how to handle this risk. Your last sentence, all industry players operate in a hybrid world with split incentives and processes, to me seems like either the road to complete failure or complete fragmentation of the provider and hospital landscape into each everybody picks what they want to be experts in, and we have total fragmentation, right? Which doesn't seem like a way forward for the country. So I guess my two questions are, first, what sort of time scale do you see that playing out over until we get to a tipping point where the path is decided? And or what do you see as the key couple of influences that will help tip us to one side or the other in deciding what that path is going to be?
Gosh, Lee, great questions, and thank you for summarizing that so well. Gosh, I have quite a few thoughts. So your first question was around, sorry, can you say your first question again? I'm agreeing to your second one there.
What's the time scale you see that playing it over?
Yeah, so when we had a whole bunch of interviews around this, one person said that the future of commercial risk is like playing the stock market or betting on the stock market and the future of that. I think it is highly variable and unpredictable. And in fact, when we've spoken with organizations, there doesn't seem to be any one clear direction of what they're trying to do. So I could see a horizon of 5 to 10 years, and it's primarily driven from the employer market. So to get a little bit into your next question of the key influences, something that's interesting is that employers are really frustrated right now. When we interview employers, they are mad at the current state and how much they're spending on healthcare. That said, given the Great Resignation and all the forces that they're experiencing, their own type of workforce crisis, they're not really willing to take any big risks right now when it comes to their healthcare benefits and making any key changes. And so I think what's causing this short term and why I don't think we'll see a ton of change in the next couple of years is the employer market being reticent to make any big changes to retain folks and attract folks. They certainly don't want healthcare to be the reason why folks won't choose to stay with them or choose them as an employer. So I think the employer market is going to be a big driving force. I think the other area that's interesting is the national health plans. When I talk to some of the national health plans, Cigna is very motivated when it comes to commercial risk. United Health Group has said that value-based care is one of their top 5 priorities right now, and so it'll be interesting to see how much they can influence given their national scope. That said, of course, in most markets, they're not making as big of an impact. So I think the health plan side is where we're seeing more pushes when it comes to commercial and less so on the provider side. Exceptions being the more progressive independent medical groups that are ready for this, and they want the consistency across their different patient sectors. Did I answer that fully, Lee?
And Walter.
So I have a question for Kristen. And first, I just want to say congratulations on LTC-ACO achieving the top per beneficiary savings in MSSP for 2 out of the last 3 years. That's really fantastic. You might know that we've been taking a journey along the population-based total cost of care models throughout this, different aspects of these models throughout this year. And our prior public session back in June was around model considerations for care delivery around these total cost of care models. And I'm just wondering what your providers did that really helped LTC-ACO achieve its per beneficiary savings. What kind of influences did your organization have, and what were the actions that really led to these savings? And before you answer, I should just, from a full disclosure standpoint, say that I'm especially interested in this answer because our practice signed up to join LTC-ACO starting January 1st of next year.
Wonderful. Glad to hear it. Welcome aboard. We'll begin onboarding momentarily. So, so we, again, can't overstate the importance of the data sharing and meeting with providers. First of all, what's been challenging is just before you even get to the cost of care and impacting the cost of care is attribution. And attribution shouldn't be as challenging as it is, but we spend an inordinate amount of time with our providers. They know who the long-term care population is, right? They're in beds. We know who they are. But getting the physician visit, and if it's a nurse practitioner group that's delivering the primary care, getting them, somehow working around this physician visit requirement. So we have a lot of activity. An inordinate amount of our value-based care resources are focused on how do we just actually work within the system to make sure that our primary care providers are recognized for the role that they have. So we spend a lot of time on that. And so in that, there's a lot of encouragement of go see your patient. Make sure you see your patient often. Make sure that care is being delivered, that annual wellness visit is being conducted, that the advanced care planning is happening. So it's encouraging all the things, again, not rocket science, but just making sure we look at the data, that the preventive care measures that we're measured by and we know are important, that's happening, showing the provider in the group over the course of the year how they're progressing in all of these areas, not just from a cost perspective, attribution perspective, but then a quality of care perspective. And so with all that said, that's a lot of onboarding. I would say the first year of performance is really just orienting our providers on this whole. And then it's where do we go from here? Once we understand the practice patterns and where folks are outliers from others, it's really digging down and focusing on, again, the use of palliative care, using the hospice care appropriately, because for this population, we oftentimes see folks that are on hospice care for 2 or more years, longer than what the benefit was intended for. And so it's using palliative care, it's having those discussions and supporting. So we have resources, we're not trying to sell ACO on this call, but supporting our providers with those palliative care. If they don't have the time, a lot of providers will say, I don't have the time to have those advanced care planning discussions. I know they're important, but I just don't have the time. And so supplementing resources and subsidizing resources for our providers so that they can get that work done if it's supplementing and they're open to it, with additional providers to go in and have some of those discussions that they're otherwise not having. But then again, there's drive to deprescribe, that we're working on medication management. So it's really at the end of the day trying to help prevent avoidable hospitalizations. I mean, there are so many low-hanging fruit, as you know, in this population. If we just pay attention and reward our providers for paying attention to the total cost of care and being available through telehealth, supplementing with telehealth, so that around the clock, there's someone to call and someone available to make decisions about what is in the best interest of the beneficiary. And it is not necessarily oftentimes going to the hospital and going to the emergency room and going through that before they come back to the facility. So again, I will say it again, not rocket science, but it really is in the execution, right? And as you know, on the front line delivering care to this population, it's the day-to-day and being with the patient at the right time. And we are just trying to arm our providers with all what the intent of the program, information to make better clinical decisions for their patients.
And Angelo.
Thank you. I know we're short on time, but so this is a question based on my previous experiences, and it's aimed mainly at Claire and Jeff, I guess. So in my experience managing Medicare patients, most of the benefit in the value-based areas are due to utilization. It's managing, identifying those patients with chronic diseases, preventing progression, keeping them out of the ER, keeping readmissions low, keeping them out of the long-term care facilities and shortening their stays in long-term care, et cetera. And that's the day-to-day approach to those patients. For the commercial population, we saw just the opposite. And so although there are some employers whose employees may tend to reflect the Medicare population a little bit, most of the employers that we dealt with and the commercial products we dealt with are 80 to 90% focused on price, site of service, and hard around procedures. And so my question is, does the commercial market care model really reflect that's needed in the Medicare market? And is there really, I know there's probably an 80-20 rule here where 20% of what we do for Medicare applies to the commercial and vice versa. But those are really, in my experience, two very different models, two different approaches to negotiations at the table, two different kinds of negotiations. So I'm interested in your views about the expectations that those move along the path of value-based care hand in hand are really realistic.
I'm happy to go first, if you'd like.
Sure.
Yeah. So, Angela, I think this is going to be the critical question that we need to answer when it comes to the future of value-based care. And my thought is that it's going to happen differently in different markets, depending on the balance of the populations and the level of partnership between plans and providers. So a crucial element of making this work is going to be having plans and providers partner around what types of compromises they can make in different patient populations. That's also why what I presented, those two different scenarios really are the futures that we expect could unravel in these different markets, and why in the commercial space we thought about there could be 3 to 5 core bundles that you focus on that would achieve some of those big cost reduction areas that you're talking about. And so there would still be a focus on population health access for everybody, primary care access for everybody, but you would have things focused on certain therapeutic procedures for commercial. Certainly something around chemotherapy is a huge cost driver in that patient population, so intentional efforts around there. And then labor and delivery was another big cost area we saw as an opportunity. And so could you have a world where you're focusing very specifically for commercial and still getting some of the broader benefits enough for everybody? And so you have some of the Medicare model where you're not discriminating against commercial, so they're certainly benefiting from some of that additional preventive care, but you have intentional focus areas just like you would for Medicare. So, I mean, we're always going to, in population health management, we know one size doesn't fit all. And so to some degree, either direction, there's going to be some tailoring, but I think the balance is going to be challenging. Angela, I don't think there's an answer to your question besides that we're going to have to figure it out as we go, because it's in my opinion, the real tension that we're going to feel in value-based care across the next 5 to 10 years.
So, Dr. Sinopoli, I agree with what Claire said, and I accept your premise. I agree with your premise to the question. I think what we are talking about are those areas where we think there is the greatest kind of overlap and impact. So, primary care behavioral health integration, really important for all populations, especially coming out of the pandemic experience. And so there's an area that I think people are increasingly talking about. I think, in my view, having been in this role for 7+ years, I think we're seeing greater payer readiness on the commercial side. And so there's also, and one thing that we promote as a task force is that Medicare Advantage provides a very flexible platform to be able to kind of advance value-based care too. And what we're hearing increasingly from the payers is as they get into MA and maybe they get into Medicaid managed care and they're obviously doing commercial, they're having, very important conversations about what are those areas where you could have the most impact. But, as an overall proposition, no, the populations are different and they create different areas. I also think it's going to be very interesting to see where the commercial payers draw the line on telehealth. Access to telehealth post-public health emergency. Medicare will boomerang back to a very antiquated statute, which is going to be problematic for a lot of people. But there's very serious ongoing conversations about telehealth and changing sites of service, even more so than I think probably prior to that. So those are some areas where I know there's at least thought that there could be approaches that would apply across populations.
Thank you.
Kristen, Claire, and Jeff, thank you so much for a very rich discussion. We're going to be breaking now for lunch until 1:30 p.m. Eastern, but we want to invite you to join us for the rest of the day virtually. We really appreciate your time and perspectives. It was very interesting dialogue, and we look forward to seeing everyone at 1:30 p.m. Eastern. Thank you.
Produced by the U.S. Department of Health and Human Services.